Welcome to British BioMedicine Institute. Today, I, Dr. Pramod Khatre, is going to represent a simple topic named as parametric and non-parametric analysis in clinical research. So basically, the data on national health and epidemiology are often collected using complex probability sample designs which involve stratifications and clustering of units. And faculty of biostatistics, they are basically involved or engaged in developing or designing such type of surveys and in developing the method of analysis. So under Bayesian statistic, these methods facilitate statistical analysis of image data across the subjects, and they also promise important diagnostic benefit through quantitative measurement of disease progression over the longitudinal match image data, and they also permit the study of rarest attributes, and or we can say current application of this method includes the study of physicians' ability to assign image consistently to the disease classes. And the methodological work include new diagnostics to assess the convergence of numerical algorithm and tools to assess the adequacy of Bayesian model in describing the population variability. So, computational statistics also play an important role. Today, nearly every statistical analysis is being performed on a computer. Some methods are particularly dependent on intensive computing or custom softwares. So, there has to be a role of fMRI, functional magnetic resonance imaging data, a single data set which consists of 100 million elements. Many create software which is used throughout the world, including tools for the analysis of the genetic data, example for genotypic error detection, or for linkage and for association analysis in the pedigree, or brain imaging data, example non-parametric analysis of PET or MRI data. Custom softwares are necessitated by the complex data structure or for graphical method for exploring clinical data. And there is another area of interest to the faculty for permutation or resampling methods which allow inferences under the weak assumptions but require analyzing variations of the data thousands of a time. And it is an essential tool for Bayesian modeling like your MCMC, Markov Chain Monte Carlo. This computationally intensive stimulation procedure is used to characterize complex high dimensional posterior distributions. Under longitudinal data, basically, there will be a correlation data which are common in many health sciences studies where clusters, hierarchical, spatial data are frequently observed. A common feature of such data is that observations are basically correlated and statistical analyses are required taking such correlations into the account. Examples of the cluster data include longitudinal data, familial data, or analysis of multiple outcome or recurrent events. Hierarchical data is common in multi-center clinical trials and community or school-based interventions studies where correlation is due to several levels of clustering such as school and classes. Under spatial data, basically it basically arises in disease mapping, ecology, environmental health or brain imaging where data is being correlated with the spatial proximity, or there will be a random effect model or estimating equations, missing data, multiple outcome, non-parametric or semi-parametric regression, measurement error models, or joint modeling, survival or longitudinal outcomes. So under non-parametric methods, in contrast to parametric modeling, where the distribution of data is assumed known up to a finite dimension parameters, non-parametric method involve an infinite dimensional parameter. Non-parametric methods are widely used in biomedical research. For example, log rank test or Kaplan-Meier estimate, a standard tool in analyzing the censored survival data. Under semi-parametric modeling, basically a semi-parametric model is intermediate between parametric and non-parametric models, which widely used Cox model, because it is a semi-parametric. In both non-parametric and semi-parametric modeling, empirical method and smoothing are two main major ways to deal with the infinite dimensional parameters. And under the semi-parametric technique, like in clinical trials, there will be a survival analysis, recurrent event, longitudinal studies, and missing data problems. Analysis of missing data. So basically, the empirical studies in social, behavioral, economical, or medical sciences frequently suffer from missing data. For instance, sample survey often have some individuals who either refuse to participate or do not supply answers to certain questions. And panel survey or longitudinal studies often have incomplete data due to attrition. Simple approaches are used to handle the missing data, such as discarding incomplete cases or filling in estimate of the missing values, of which often leads to bias or inefficient statistical interferences. So under the survival analysis, basically in many medical and scientific studies, investigators are interested in analyzing data on time to an event. And applications to this work arise in areas as diverse as medicine, epidemiology, demography, and engineering. In such event history data, interest center on timings and occurrence of various kinds of event, such as repeated infections, recurrence of the disease, or sequence of event that occur throughout the clinical study period. The analysis of survival data is an area of great strength. It includes frequentist or Bayesian methods which are being developed by the institutes. Bioinformatics. Basically, biomedical research is a information-based discipline which is undergoing a major revolution as a novel experimental approaches yielding in unprecedented amount of clinical data. Automation and robotics are becoming integral part of academic processes, impacting the way academic and industrial research are carried out. Experimental biology or medicines, they are becoming increasingly dependent upon the extensive application of statistic information sciences. Bioinformatics is basically an interdisciplinary field at the intersection of life and quantitative science, which provide a necessary tool and resources for this endeavor. Modern fundamental and applied research in the life science are critically dependent upon this relative new field, and developing procedures for this for the analysis of data such as SNP, single nucleotide polymorphism, or protein expression data, and modeling technique for the systemic biology. Brain imaging. Basically, recent advances in the brain imaging technology allow the measurement of brain activity of the intact living human brain. For example, investigation of psychology use functional magnetic resonance imaging (fMRI) to identify the brain regions which are responsible for working memory, the short-term memory used to retain, for example, a glossary list. The secondary use PET, progesterone emission technology, or fMRI, to study the schizophrenic patients in order to understand how their reactions to the emotionally proactive images which differ from that of normal control. The statistical methods applied to this area are computationally intensive, and they include Bayesian and massively univariate classical approaches. Cancer. The statistical methodology development is basically an integral part of these projects, Example of this are the development of methods for the analysis of microarray data, developing methods to combine biomarker, developing more efficient designs for phase 1 clinical trials, and developing methods for evaluating the surrogative endpoints, missing data problems, and developing joint models for the longitudinal or survival clinical data. Initial trial design issue. So the quality of economic information that is derived from the clinical trials depends upon the attribute of the trial design. That economic analyses are often described as being conducted alongside clinical trials, which is indicative of an important practical design issue. Economic analysis is rarely the primary purpose of the experimental design study. Nevertheless, it is important that the analyst contribute to the design of the study in order to ensure that the structure of trial will provide the data which is necessary for the high quality economic studies. Under appropriate trial design, basically there is a distinction between the pragmatic or exploratory trials and the corresponding distinction between the effectiveness or efficacy is well understood in clinical trials. It is generally acknowledged that the pragmatic effective trials are the best vehicle for economic studies. However, it is unusually necessary to undertake economic evaluations earlier in the development cycles where the focus is on the efficacy, including phase 3 or phase 2 drug trials, in order to provide timely information for the pricing, reimbursement, and the reports are meant to apply for both types of clinical studies. Large simple trials are efficient in addressing clinical questions because they capture the main effect of the treatment that have small to moderate impact on large potential population. They will also be efficient for answering economic questions for disease or treatment where the bulk of cost derive from the primary outcome that are measured in the clinical trials, or for which the quality of the life impact is persistent and thus it can be measured infrequently. An ideal follow-up period for an economic study is independent of the occurrence of the clinical event, whether the study is related or not. All patients should be followed for a common length of time and full duration of the trial. Discontinuation of clinical data collection due to clinical event will fail to capture the important aspect of the disease under the study, the adverse effect of the disease on quality of the life, or resources used, or the cost. So under sample size and power, it is in an ideal world, the economic appraisal would be factored into a sample size calculation using standard methods based on asymptomatic normality or by stimulation. However, it is commonly for the common sample size of the trial to be based on the primary clinical outcome alone. As a consequence, it is possible that the economic comparison will be underpowered. The analysis should calculate the likely power of the clinical study at a design state in order to ascertain whether the given proposed sample size it makes sense to undertake an economical appraisal. In many cases, the sample size restriction will necessitate focus on estimation rather than hypothesis testing of the economic outcome. In cases where researchers wish to set up formal hypotheses for the economic analysis, these should be stated a priori, including the threshold and the power to detect when incremental analysis meet or exceed these thresholds. Now comes the endpoint. So basically, the choice of primary endpoint in the clinical study may not corresponds to ideal endpoint of economic evaluation, or we can say the use of composite clinical endpoints are common in clinical trials like fatal event, non-fatal event, or even they are combined, in order to provide greater statistical power. However, cost per composite clinical endpoints are often an unsatisfactory summary which measures for an economic analysis, in part because the different outcomes are rarely for equal importance. Weighing endpoint so they yield a measurement of quality adjusted life years, QALY, is the case of cost effectiveness analysis, or we can say a monetary benefit, which measures in this case, or in the case of cost effective analysis, cost benefit analysis. Alternatively, quality of life value may be obtained within the clinical trial at regular interval or at QALY, estimated at one of the outcome in the clinical trials. If possible, one should avoid using intermediate endpoints like your percentage LDL reduction as the measure of benefit. However, intermediate outcome measures are often employed when the cost of conducting a large term trial are prohibitive. When use of intermediate outcome is unavoidable, additional evidence is required to link them with long-term cost and outcome. If such a link is not reliable or it is not available, then the analyst should argue for follow-up sufficient to include clinically meaningful disease endpoints. So under the follow-up conditions, there has to be an economic analysis, ideally including lifetime cost and outcome of the trial. However, clinical trials rarely extend beyond a few years and are often conducted over much shorter period of time. In practice, consideration of follow-up period for the trial involves the relationship between intermediate endpoints gathered in a short run and long-term disease outcome, or we can say the stronger the relationship, the more a reliance on intermediate endpoint can be easily justified. Outcome: when one of the clinical trial endpoint are also used as an outcome for the cost effectiveness analysis, like in trial mortality, it is generally most transparent to adopt the method which are used in clinical analysis for the primary analysis plan, particularly if the clinical results are cited in product labeling or in publications. In some cases, the clinical analysis method are not appropriate for economic analysis. Example, clinical analysis may focus on relative treatment difference, while the economic analysis need absolute treatment differences. And if the other outcomes are used for economic analysis, then the linkage between the clinical and the economic measurement should be clearly specified. Analysis of cost of the outcome for the cost effectiveness study may employ multivariables or other methods that are consistent with the cost analysis or otherwise appropriate for the clinical data. Cost effectiveness analysis should still be performed when the clinical study failed to determine a statistically significant difference in the clinical endpoint. In situation where cost minimization analysis is conducted, the analyst should conduct a joint analysis of the cost and outcome in order to convey the information about the likelihood of intervention being cost effective. So under subgroup analysis, basically there is a danger or there is a risk of spurious subgroup which can affect for example, the probability of finding a difference due solely to random variation increase if the number of differences examined under the alpha level is scrupulously adjusted. And the economics require a marginal approach, so proper subgroup analysis can be vital to decision makers. The focus should be on testing treatment interactions on the absolute scale, with a justification in the choice of scale which are being used. In case when pre-specified clinical interactions are significant, subgroup analysis must be justifiable. So under the method of analysis, basically there is a construction of cost and outcome. In case when the main clinical endpoint is used in the denominator of the incremental cost effectiveness ratio and differential method were used to analyze this endpoint in the clinical or economical analysis, any differences in the point estimation should be explained. And there is a method for addressing missing and censored data. Statistical methods they can use to compare resources use, cost and outcome. And there is a method or assumptions which is being used to project the cost and outcome beyond the clinical trial period. And if there is any deviation from the pre-specified analysis plan, and justification of these changes can be done. So I hope you have gained a lot of clinical information through this presentation. Please like, share, subscribe our YouTube channel named as British Biomedicine Institute. Good luck. Goodbye.